Hi, welcome to Conversations in Interventional Cardiology. My name is David Rizik, and I am coming to you from the Honor Health Medical Center Cardiovascular Center of Excellence in Scottsdale, Arizona. I am the Associate Editor of SCAI and the Chief Scientific Officer at Honor Health Medical Center. I'm honored to represent SCAI and Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jscai.org, that's JSCAI.org, or follow us on X, formerly known as Twitter, at myJSCAI. JSCAI is the home of all official SCAI documents. We're exciting next 20 minutes for you. We're here today to discuss an important document recently published in JSCAI entitled Reverse Left Ventricular Remodeling with Transcatheter Interventions in Chronic Heart Failure Syndromes, an updated appraisal of the device landscape. And I am joined by some tremendous experts and leaders in the field. First, Mickey Brener, who is at Columbia University and the New York Presbyterian Hospitals. Mickey, it's a real pleasure to have you. Dan Burkhof, Director of Heart Failure, Hemodynamics, and MCS Research at the Cardiovascular Research Foundation. And certainly one who needs no introduction, Mark Reisman, who is the Director of Structural Heart Disease at New York Presbyterian Queens and New York Presbyterian Brooklyn Methodist Hospital in New York. Thank you so much for joining me. Mickey, we're going to turn it over to you. I think this is an incredibly important area of clinical investigation and research for 2023 and 2024 and beyond. I know you have a PowerPoint to share with us. I'd like to turn it over to you. Dr. Brener?
Thank you, Dr. Rizik, and thank you also to JSCAI for having us. We're excited to share this review article with you. We agree that this is an important hot-button topic right now in cardiology. And the goal of the review was really to share some of the most recent research that's been conducted in the field. Here, I'll pull up my presentation. I presume everybody can see it now. I should also just pause. I wanted to also recognize Dr. Kapadia. He was one of the co-authors on this manuscript. Before we sort of dive into some of the devices, it's really important that our readers and our audience understand the fundamental concept of heart failure. And if you followed any of my work and Dr. Burkhof's work, you know that we like to resort to the pressure volume diagram, the PV loop diagram, because it can help explain how these devices work and what they're actually targeting or what they're trying to accomplish. So in teal, you can see the normal left ventricular pressure volume loop. It's a curve that's bound by two fundamental relationships, the end systolic pressure volume relationship and the end diastolic pressure volume relationship. The ESPVR summarizes left ventricular contractility, and the end diastolic pressure volume relationship summarizes diastolic properties of the ventricle. And you also see there drawn in the dashed line is effective arterial elastance, which is a concept that we use from the previous diagram to relate left ventricular afterload. And so the fundamental problem or the issue that kicks off heart failure syndromes, especially with reduced ejection fraction, is a decline in contractility. And so you can see in the pressure volume loop in red, there's a new EES line, or end systolic pressure volume relationship, that has a slope that's smaller than the normal left ventricular pressure volume loop. And in order to compensate for that, the left ventricle undergoes a number of rearrangements in order to compensate and maintain stroke volume. The first thing that you'll see effective arterial elastance, or the EA line, increase in slope. And again, the purpose of that is just to maintain perfusion pressure to all the vital organs. And then you also see, importantly, a right shift of the pressure volume loop to higher and higher volumes. And the purpose of that is to maintain stroke volume. And so once you sort of understand that fundamental concept, it's not hard to realize that the goal of most heart failure pharmacotherapy, as well as devices, is to bring that pressure volume loop, the red one, the sort of one describing a heart failure condition, back over to the normal side, reduce left ventricular volumes while maintaining stroke volume and perfusion pressure to the organs. And there are two fundamental ways in which we believe this reverse remodeling process can occur. This is a concept that Dr. Burkhof and I have been promulgating sort of in the literature over the last few years, that there are two fundamental ways in which reverse remodeling can be achieved. First is biological remodeling. This is where we are actually changing the loading conditions under which the ventricle is operating on. And then the second modality is physical remodeling. This is where we directly physically reduce LV mass, chamber size, or geometry in order to bring the left ventricular pressure volume loop back over to the left side. And you can see in the figure here on the right how we've summarized a number of different treatments and modalities according to their primary mechanism of action. And we should note that there are a lot of devices that actually combine both physical as well as biological means of achieving reverse remodeling. Throughout the review, and again, we encourage everybody to take a look at the review, we go through a number of the key devices that have recently been published on, sort of categorizing their primary mechanism of action and how they achieve reverse LV remodeling. You can see that in the sort of upper half of this figure, there are the primarily biological means of reverse remodeling. In one category, we have valve-directed therapies. Our audience is probably familiar with the TAVR revolution, as well as with a number of devices that are on the market for reducing mitral regurgitation, most notably the edge-to-edge repair devices, both MitraClip and Pascal. And then we also have a variety of new devices that attempt to, for example, reduce mitral regurgitation through the coronary sinus. In addition to these valve-directed therapies, there are classic mechanical heart failure therapies like the LVADs, and more recently, cardiac contractility modulation. And these devices, which have, again, a primary biological means of enacting left ventricular reverse remodeling, are in contrast to what you see in the bottom portion of the figure, which are the physical reverse remodelers. This is, again, where we're just trying to change LV geometry or change LV size. You have the classic partitioning devices, which recapitulate a lot of what was done in traditional surgical techniques. For example, the Revive and TC device, as well as the parachute. As you can see, it sort of occupies the apical portion of the heart. And these are similar in nature to some of the reshaping devices that have been featured more prominently recently, like the AccuCinch device, as well as very recently in preclinical models, the Mirth technique. And we've summarized in the table here. It's a lot to digest for sure. And the purpose of bringing it up is not so much to go through each point, but rather to direct you again to the review article, where you can see some of the clinical evidence that supports both the biological as well as the physical mechanisms of reverse remodeling. What you will see, and what I've sort of summarized here in this final slide before we get to the discussion, is that in general, biological remodeling mechanisms can be very effective. The key or sort of operative word there is that they can be effective. The response, as we know from our clinical practice, is not uniform, and the benefits may be delayed. Patients, for example, may have reverse remodeling with biological devices as well as pharmacotherapy, but it may take too long to achieve a real, true, and lasting clinical benefit. And in contrast, physical remodeling devices may be helpful, but they have to, at the end of the day, be combined with some sort of biological mechanisms of reverse remodeling to reinforce some of the changes in LV mass or geometry that these devices are able to achieve. And it's important to recognize that their success ultimately depends not only on their ability to be combined with these biological reverse remodeling effects, but they have to be safe, because ultimately these devices need to be implanted with a good safety signal. So I think with that summarizes the gist of the review. I'll hand it off back to Dr. Rizik, and we'll open it up for discussion.
Wow, this is really great stuff and really groundbreaking stuff. Let me ask you a question. You know, though I have a PTSD moment every time I see a pressure volume loop, should these be performed on patients routinely as a means of guiding our therapy, understanding where each individual patient is in the spectrum of disease?
That's a great question. I can assure the audience I didn't ask you to ask that, but we don't want you to have a ghastly reaction to every pressure volume loop. We feel like, especially as the interventional cardiologists and cardiologists at large are getting more involved in structural interventions and getting involved with hemodynamics, it's important to understand the underpinning of a lot of what we do. So we're trying to take out the sort of bad reactions that come with looking at pressure volume loops. We do feel like at this earlier nascent stage for a lot of devices, pressure volume loops can provide a lot of really valuable information, sort of take away some of the problems that we have with non-invasive assessments of LV function, or in general in ventricular function that comes along with echocardiograms, even MRIs, et cetera. And so there is certainly a role for pressure volume analysis. Is it going to become a widespread clinical tool? Most likely not. There's still something that needs to be performed at specialized centers that have a lot of experience with it, but we do feel as though pressure volume analysis can be a very meaningful tool in the early stages for device development, sort of really understanding the hemodynamic impact of different interventions, and then ultimately translating that knowledge of how how the device is actually working on the ventricle to its ultimate clinical impact.
It sounds like we need to go back to the drawing board in training programs and really emphasize this. Would you agree with that?
Maybe I can also kick in, because a lot of the work that we do is to what we refer to as to demystify pressure volume loops, and also to take away that PTSD from medical school. And so I'll just put a little plug in for we have an educational program called TEACH, Training and Education in Advanced Cardiovascular Hemodynamics, which is an interactive program where we use our Harvey simulator, which is an interactive tool where students can change parameters and see in real time the pressure volume loops, how they change, and get a new perspective on preload, afterload contractility and diastolic properties. So we put on programs that range from 1 hour to 4 to 6 hours, 7 hours, where we go through the basics and also a very large number of clinical scenarios, including shock, mechanical circulatory support of all sorts, as well as in some of the more advanced ones, biventricular failure, ventricular septal rupture in the setting of MI, all the valve lesions, et cetera. But the bottom line is that to really understand physiology of the cardiovascular system, you can't just look at signals on the screen, pressures and EKGs. That doesn't get you very far in terms of understanding physiology. It's really through the window of the pressure volume loop that everything becomes very clear. And in comparison to all the things that interventional cardiologists and cardiologists do and know, pressure volume loops should rank among the simplest to understand. And it's really just a matter of overcoming that initial hurdle of that is.
You're absolutely right. Yeah, you're absolutely right. That initial reaction to it. So Dan, I kind of feel like Michael J. Fox in Back to the Future. Haven't we seen heart failure surgical therapies not fare so well? What makes us think that as we look at the spectrum of catheter-based therapies, they will fare any better?
Yeah, that's a great question, because there has been a very mixed history of structure, of physical remodeling approaches, namely, especially very early on with what's called the Batista surgery, the door operation, aneurysmectomy. If we look at the surgical approaches, that kind of covers the spectrum, at least in terms of the not necessarily in terms of the surgical technique, but in terms of the spectrum of patients that have been approached with these techniques. Door procedure being for global idiopathic cardiomyopathy, door for akinetic anterior and scar, and aneurysmectomy for really truly a dyskinetic scar. So I think some of the jaded history is related to patient selection and the actual how the surgeries were performed. I think if you take the two extremes, I think we really know, we think there's not been a randomized study, but that aneurysmectomy works very well to improve ventricular function and outcomes. We don't have hard randomized trials in that, but I don't think we're ever going to have a true randomized study in aneurysmectomy when you have a true bulging dyskinetic aneurysm. On the other extreme, the Batista operation, which took out functioning muscle, we know harmed people, created severe diastolic dysfunction when, depending on how much of the muscle was taken out. So there's a spectrum of taking out functioning, the weak but functioning muscle, and dyskinetic scar. And it's really when you exclude these or excise these different types of materials, it has differential effects on systolic and diastolic properties. And what you want to do with a remodeling, physical remodeling, is to have a greater effect on systole than on diastole, so that the heart can relax, but also contract better.
Does it beg the question about the relationship between LV volume reduction and any benefit on survival?
Well, that relationship, which is known for drugs, drugs that reduce end diastolic volume are associated with improved survival. We know that. But that doesn't, and that was really what was behind the Batista operation. Surgical thinking. Heart's big, make it smaller, and things will get better. It's not that easy. So it's a matter of how you make it smaller and how much you affect diastole versus how much you affect systole. And what I think is happening with the percutaneous devices, for the most part, we don't take out muscle. We leave muscle, but we just reorganize the geometry. So I think that is that's one of the benefits of the percutaneous approach, and it's really about reducing the radius of curvature of the chamber, which reduces the wall stress for any given pressure. Or said another way, for any given wall stress that the muscle can generate, it will generate more pressure when the radius of curvature is smaller, meaning that it can hopefully translate into a higher contractility. So a lot of it is how effective these devices are in changing the shape in a favorable way, but not taking out the muscle, leaving contracting muscle there.
All right. So Mark, taking what Dan has just said and the presentation that Mickey just gave, you're the world's leading authority on new device investigation. I've learned so much from you in both the cath and the cadaver labs. I always think about new device adoption, how broadly applicable something is. How would you calibrate the spectrum of therapies that Mickey discussed? How would you calibrate these therapies in terms of ease of use and adoption in the community hospitals?
No, I think it's a great question. I just want to make a couple of comments after some of the thoughts that were shared by both Mickey and Dan. Number one, I do believe it's important we step back and think about the pressure volume loops and study them really in a number of very, very common clinical scenarios. We know we often are sitting there after a mitral clip and see what we're sort of reflections of what's happening hemodynamically, either by echo or measuring pulmonary vein flows or looking at a static LA pressure. But we really don't have a great sense often, even in the most basic valvular cases, what really is a good result, what's really going to benefit the patient. So I think we do have to create a library of information that's informative for ischemic, non-ischemic, different degrees of LV dysfunction, response to certain medications. And once we have that library and understanding, then we can start inferring some of the data we get after doing our procedures to help guide us manage patients. The second thing that sort of is more reflective of your question is, how do I interpret this? Well, I don't want to say I'm enlightened by any stretch of the imagination, but I spent a lot of time, with Dan and with Mickey, and I've sort of, watched from the sidelines to some extent their work and how impressive it is in directing therapy. And then the concept of reducing, the LV mechanically, and then collaborating with heart failure and GDMT and making sure that we take that sort of mechanical advantage and then use medical therapy really resonates with me. And a lot of these procedures are different and new, but at the same time, they're sort of related to things that we do. So if you take, for instance, the Ancora device, which is a cinching device where we're going around the left ventricle, we're starting to get a lot of experience with some of the valve procedures like the M3 procedures, a technology by Edwards. So I believe that within the armamentarium of managing patients and the, I don't want to say insidious, but the natural progression that we've seen in heart failure, that we are going to need physicians really focused on what I'll call interventional heart failure therapies in order to manage these patients, because the impact is so dramatic. And you asked the question, how does this affect mortality? We're not even talking about symptoms anymore. We're talking about, a real mortality. And even though we've seen, almost spectacular results from COAP, still the mortality at time points like 2 years and 5 years is still very, very high.
When we start talking about contractility modulation and partitioning devices, Mark, it sounds to me like this is a specialty within a specialty within a specialty. These are going to be people dedicated and devoted only to this. Does that resonate with you?
I think that maybe technically it could be a shared field, but in terms of managing these patients and really knowing how to do nuanced, sort of therapies for the patients physically is going to be important. I think personally that we almost have to create a landmark, within the last 2 or 3 years. And I don't want to say forget about what has happened previously, but I think at least we shouldn't let that slow us down. I think there's a lot of enthusiasm around transcatheter therapies. The good thing I've seen from most of the data that's become available is that they're often very safe, and they often don't take away options that have already been proven in advanced heart failure, like LVAD and transplant. So, whether we're just pushing things out several years, which is not a bad thing, or we're creating a durable therapy, which would be a wonderful thing, I do believe that we have to start creating the field right now. So when you see the groundbreaking work that Dan's done and now Mickey is doing, I think it really constitutes an important new platform to now start managing these patients.
One thing I can add to this discussion is, as you all know, there are increasingly still small, but increasing number of young cardiologists that are getting dual trained in heart failure and intervention. And, there's a lot of discussion now, is this worthwhile? What kind of jobs do these people get? Are there enough jobs? Are they accepted in the cath lab? Are they accepted in the heart failure? Where do they really live? But I think that the concept of people dual training, gives interventional people a greater appreciation for what's happening on the medical side and what the options are for the heart failure physicians. And on the heart failure side, knowing more about interventions really, gives a leg up and really helps expose the patients to a much broader range of options. So I think that we're going to see more of this, and how this field of this profession of so-called interventional heart failure evolves is going to be extremely interesting over the next couple of years.
I'm sort of reminded, Dan, as you're talking, I'm sort of reminded of, in where I work, we have orthopedic surgeons who only do knees. We have orthopedic surgeons who only do hips. We have orthopedic surgeons who obviously only do hands, and they are busy from sun to sun. Is that what interventional heart failure may evolve into?
Mickey, you're closest to the training and seeing some of your colleagues go through this.
I think I mean not to put a damper on interventional heart failure, but it's a challenging landscape. I mean, just today,
Yeah, of course.
the match, for example, for intervention, for advanced subspecialties in cardiology, and the reality is that most advanced heart failure positions are not even filled. So finding a workforce that's going to be able to scale for interventional heart failure and get people to sign up for more training is going to be very challenging. And I think, going back to what we were discussing to your first question, Dr. Rizik, are these devices going to be democratized and available in the community? Well, I think that they can be. And I think actually structural interventional cardiologists are the ones who need to lead that charge. We have familiarity with large bore devices. We're comfortable with that. We have familiarity putting those devices inside the heart. So we check off a lot of the boxes, and it's up to us as a community to be comfortable and facile with the physiology, with interpreting and reacting to hemodynamics. And so I think that there's definitely going to be a role for interventional heart failure. There's definitely going to be a role for the, uber specialized interventional heart failure physicians that are putting in some of these devices. But I look to a lot of the devices that we profiled in the review, and I say, I think a structural cardiologist or even a very, good interventional cardiologist could do that. And I think that's where really the name of the game is, because ultimately we know that there's a massive need for improving outcomes for patients with heart failure. And so the need is there. So that means we have to respond to the need in a way that's practical. And I think interventional cardiology, and in particular structural cardiologists, are going to play a huge, huge role first, probably before interventional heart failure catches up.
Mark Reisman, last word.
Yeah, I think it's really exciting, and I think any young person or mid-career person or more mature interventionalist or heart failure person has to embrace this field. Most of it's investigational. We need the best and the brightest to participate. There are going to be some misses, and there are going to be some home runs, and there are going to be some base hits. But I do believe, with what we're seeing around, the challenges in heart failure, the challenges in valvular diseases that are very insidious, like TR, and what we're seeing in secondary MR, I think the importance of this is going to continue to grow, and I think that a joint group, AHA, ACC, SCAI, needs to really get together. And I know the role of the hemodynamicist is not a role that's often described anymore, but we really have to start thinking about just being very comfortable with interpretation of hemodynamics, getting appropriate tracings, being able to use them in a facile way so we can make really good decisions for our patients and study the right patients, frankly.
So now I've hired coronary interventionalists, coronary specific interventionalists for Honor Health. I've hired structural interventionalists for Honor Health. Now it sounds like we need to be looking for interventional heart failure specialists in our programs. What a great discussion. I'm honored to have represented JSCAI, and again, Editor-in-Chief Alexandra Lansky, who's been leading this for JSCAI. Remember, you can find us online, jscai.org, that's JSCAI.org, and follow us on X, formerly Twitter, at myJSCAI. JSCAI is the home of all official SCAI documents. Thank you, Dan, Mark, and Mickey. What a great discussion. Good evening.